Our next speaker, Dr. Chip Cole from Atlanta, the eye guy. InsideOut Facelift with no facial scars or tragal ear deformities. I think we were at Oxford about 35 years together, aren't you? 35 years ago. Yeah, good to see you.
Thank you. There's been some excellent presentations today, and we'll try to bring it all together. With the InsideOut Facelift, the main point is there's absolutely no scars on the face or anything that can be visible. This slide is not advancing. Oh, right here. All right. I have no disclosures. The worst four-letter word in plastic surgery is scar. We never talk about it, but if you look at it from a patient perspective, they feel completely different. We love to say my patients don't complain. That's because we tell them we're going to put a scar there. The two reasons that surgery has lost popularity is scars and general anesthesia. Look at this sequela of a typical facelift that I see every day referred to me. Is this necessary or is it just convenient for us? You know, we talk about preservation of many things like the gray line, the white roll, the columella, but we don't give any respect to the tragus. So Rodney is pissed. So if you look at a normal ear, when you look at that beautiful tragus, I like to call it a tragal collar. And I think it's very important to preserve it. There's a lot of relevance, both anatomically and social. The vagus nerve interacts in that region, and it has a lot of treatment with migraines. And Forbes has said that this is a future $200 billion industry. Steve Forbes has given me public endorsement, so this is not a HIPAA violation. But one of the things he says is to be successful, always use and improve things that you like and understand. Back in the 80s, I did a lot of research on scarring and wound modulation with brown recluse spiders and envenomation. I learned a lot about scarring, and so when I have these patients come to me from a board-certified plastic surgeon that was ranked last year top 10 plastic surgeons in the United States, and she can't even close her eyes. These are tough repairs. Or this lady comes in with poorly designed facelift incision. And this is with hyperbaric, this is PRP, it's everything. But that's what she ends up with. Same thing here. Poor approach, she goes in for a cosmetic result. We all have these kind of patients too we have to think about. I love the mini lift idea, but I want the maxi result. So it all has to do with education. You have to break it down, put it in terms the patient can understand, because all the action is actually between the sheets. This is a typical lady that comes in. She's had five surgeries, 3 different plastic surgeons, and she says, I just want my eyes to look like my granddaughter. We all have the same eyes. I say, well, that's pretty reasonable. Bring in a picture. She brings me this, and I'm like, uh-oh, I'm in trouble. But eventually, all of these people turn into what I call a marshmallow face. They get filler fatigue. They get tired of camouflaging, and they just can't spend any more money. So we take somebody like this that used to sing about the material girl, and she has become the material girl. God knows what's inside there. Or we take the most powerful person in the world, and he has a pixie earlobe deformity, tragal deformity, lateral sweep, and this is what he looked like before. So do we really need that tragal scar? Every procedure has a safety box. This is paramount in anything we do with a society. But you have to realize that every master was once a disaster. So I want to take my experience and basically take you from being smart to being wise, which you learn from your own experience. But if you can learn from others' experiences, it makes you a genius. I hope you'll be a genius facelift surgeon after this talk. The ideal facelift, most of us agree, except I feel like it should have no scars. So I can take somebody like this in 1 week in deep neck work, no scars on the face. Here she is at 2 weeks. Look at the cheek elevation. Look at the improved contour targeted to the center of the face. So to me, somebody that has an older look has that ovoid egg shape. and a younger is targeted, a circle in the middle of the face that I like to call the Oculus for being a circle. Here she is at 1 year. She sent me a selfie. I apologize. She's from out of town. But this person is a 20-year follow-up. Slide in the center is 10-year result. Slide right is a 20-year result with a pretty good longevity of this procedure, no scars. And things have changed in the last 35 years. The goal was to look like this attractive person on the left. Today, on the right, it's not only a goal, it's an expectation. So we've got to think about our competition has also changed with social media and other things. Amazon Prime and Meta are our real competition. So we all look at the face, we know what we're looking at, but do we know why it's occurring? That's what I want to break down. It all has to do with deep fascia and superficial fascia. The deep fascia is on the lateral side with the muscles of mastication, and the superficial is involved in the facial muscles. That's why you can cook a gator and some snake at a tailgate party, and everybody else is just a grilling chicken. So the facial retaining ligaments, there's 10 of them, 5 major, 5 minor. The most important thing is these ligaments go from bone to skin, not bone to bone like the rest of the body. Upper slide right, you can see from bone to skin. So just below it, you can see when the muscle contracts, the face wrinkles. That ligament has to be addressed to get a good result. And when these all originate from the bone, look at all the spaces in the face that you cannot have the ligaments. So remember this picture. There's not a lot of places that the ligaments originate from. And that's why we all play tennis and golf. Junction, junction, what's your function? We remember that from kids. Well, this is Spaghetti Junction in Atlanta, basically several highways to hell. But if you look in the face, we have a spaghetti junction too, right in the center of the face. So imagine if we could somehow go through that hazardous area without getting into trouble. Well, we have to remember the upper and lower branches of the facial nerve, 2 finger breadths away in the anterior third of zygoma, and of course, marginal mandibular down below. So there is a staircase to heaven, but you have to know how to get there. And it's anatomy, it's tunneling, and it's using an endoscope. You can literally go from the top of the head down to the hyoid in one plane without making an incision in the skin. To do this, you have to major in minor ligaments. The most important one is the cervical ligament in the platysmal area. There is a hammock that supports a platysma, and that's why the deep neck starts to sag, very similar to a pelvic floor. And if you see a gentleman like this, there is no way, because if you look on slide right, you can see his platysma. Unless you're going deep platysma, you're not going to improve this neck. And if you're jabbing things under the platysma without any sight, it's a little bit hazardous, because just lateral to the submandibular gland, outlined in green, are all the facial vessels, and these are major bleeders. So this Christmas tree ligament has to be addressed. To me, there's no reason, using an 80-20 rule, that you should make a skin incision at all on the face in front of the ear. You go about 3 centimeters in front, and you have to remember when you're dissecting in the SMAS region, you have to use your BS, because if you're below, you have to be blunt. If you're superficial, you can be sharp, because the deeper you go, the more you should know. So as we enter this space about 3 centimeters in front of the ear, we go into this nice, beautiful cave. And if you look closely, the nerve is below you, which is different than the upper face where the facial nerve is above you. The platysma is vertical in the neck, and it crosses over horizontally above the jawline. You can examine a patient and see the horizontal lines of the platysma. Whereas when you look at the masseter, these are vertical fibers. That's important when you're looking down on these nerves to know where you are. And this is a good clinical example. Ear on the bottom right, looking at the right side of the face, and you can literally see the buccal facial nerve and the floor underneath the masseteric fascia. So when you take a person like this, always think addition to the face, subtraction to the neck. This is a psychiatrist that came to me and he said everybody thinks he looks like a patient. So he wanted to basically shift his volume, nothing unnatural, but he's got this avocado in his neck. So I go down and I address that area and try to put things back in a reasonable way, taking them from that oval to a more targeted circle centrally. And here he is at age 26, 30 years later, his post-op after a year and a half. The key is the hyoid bone, just like the inferior oblique and the lower lid. You have to understand and find the hyoid bone in the deep neck. The central neck is fairly devoid of vasculature. Like I said, it's lateral to the submandibular gland. If you follow the digastric down, right where it turns at the hyoid fascia is where you're going to find that submandibular gland. And the mylohyoid is your best friend. That's basically the floor of the mouth, like the pelvic floor. A good trick is to have somebody put their tongue on the roof of their mouth, depressing the floor of the mouth, and then you can palpate or visually see, like this area of her neck, size of a walnut, which is her submandibular gland. Another thing that's important is what I call the tic-tac-toe rule. Everybody thinks you need to remove all the skin, but if you take equal squares, you look at pre-op, it only takes up 3 squares. Post-op, it takes up 5. So the redistribution of the surface area is the reason you don't need skin. Every lump and bump is not a jowl. This is our friend Paul McCartney, and you can see that he has a prolapsed buccal fat just below the corner of his mouth. And if you look at his young picture, you can see on his left side, it shows early signs of that. So you can take a gentleman like this that has chubby cheeks and reduce him and give him a more satisfactory look. I also did his eyes. So it's interesting with art that everything starts with a circle. They know that things are targeted. And they also use concentricity. So if you put those together, we come up with things like curves. And an OG curve is we always want to augment it in the cheek, but we want to reduce it in the jowl. When we see these irregularities in the lower jaw, what we want to do is reduce that so that it's basically flat. This is an important slide to think about. This person on slide left had her fat placed in the wrong position, too low in her cheek, and has all these irregular looks. There are no edges or corners in beautiful faces, architecture, or art. So remember, improve things you like and understand. I've been working with fat since I was 15 years old. It used to have 31 flavors. And I made about half as much as I make now, $1.35 an hour. And so I learned that with a 2.5 ounce scoop, that's a perfect volume in both cheeks. So you need a half a scoop of ice cream in both cheeks, and you have to put it in the right place. If you misplace that fat, you will basically shift all over yourself. So when we think about the influence of the brow, why do we call them angry birds? Look at those brows. That's the only difference in this picture. So 30 years ago, I started talking about brow contouring and talked about endoscopoid contouring, not even using endoscope. Everything recycles. Now, in the last year, people are talking about like it's a new procedure. So just like Sir Isaac Newton said, we all stand on the shoulders of giants, and I have too as well. My main mentors have been these 6, and I'm happy to share the podium with Jeff Klein, who will give the Webster lecture tomorrow. True beauty, what is it today? It's basically an accumulated averageness. It's what I call the avatar effect. So sometimes you just have to come out of your cave and realize you might have to recreate the wheel. You're not going to always do things like you learned 20 years ago when you were training. Here's a great example. Bella Hadid voted the most beautiful person in the world. Well, if I do an upper blepharoplasty on Spock, is he going to be the most handsome in the world, or maybe the most interesting? So there's something called the golden ratio. We always talk about it, but it's really academic issues. You cannot use this clinically. And there's concentricity with 3-dimensional interaction, but it's confusing. But if you can isolate that with gravity and release the ligaments, you have a targeted approach. This is off a website of a board-certified plastic surgeon bragging that he has only 70 centimeter scar. So think about, do you want 70 centimeters of traditional facelift, or do you want 7 centimeters total that's hidden in your mouth and in your hair? Blepharospasm is something we saw a lot in the 80s, where we would have to remove all these muscles called extirpation so people could open their eyes. So extirpation is a partial destruction. And then there's important things that we might need to know as facial cosmetic surgeons about the benzene ring in organic chemistry. And that's absolutely nothing. But embryology is a different subject. It's important because the brachial arch 1 goes over, and that gives us our masticator, our survival muscles. Whereas brachial arch 2 is important for facial expression. It drags the facial nerve over, which is why you see it under the mesenteric fascia. That's the moneymaker. It's the social function. That's why the patients come to us. We should have t-shirts, go brachial arch number 2. There's a lot of ligaments in this area. It's already been discussed at length. The most important is the zygomatic ligaments, what I call the net. There's many ligaments and many attachments in that area. If it's not freed up, you're not going to get a good result. So we've seen the outside, we've seen the inside. Let's jump into a facelift. This is Evel Knievel, Caesar's Palace. And this is my instrument of choice. But if you look at the purple on the right, that's the zygomatic muscles. That's the takeoff ramp that you have to do with this procedure. So as you're going along, as long as you're above the zygomatic muscles, there's no way you can damage the facial nerve. But what's important is your landing. You have to plan your landing because you're going to be sitting in a space under the platysma. Are you going to end up above the platysma, at the jaw? What are you going to do? Well, the thing you want to remember is if you had a dry ice cube, you want to avoid that area because you will be burned by Madame Marge. You don't want to cut the margiomandibular and have a crash landing because people carry precious cargo. So there's lots of ways to remember things. I like to keep it simple. Concentric ossicutaneous ligamental extirpation. That's what this InsideOut facelift is, and we're going to get into more detail because the devil is in the details. Most people don't realize gravity is the enemy, and it is the devil. So it all depends on belts and suspenders. There's a frontalis belt, orbicularis, smas in midface, and platysma. We know that belts have strong buckles. We know that belt loops or ligaments hold these belts. And so, as an example, the lateral canthal tendon holds the lid and the canthal angle. The zygomatic musculature determines the mouth angle. Sometimes you just have to reset those radial belts to build a new tire. And suspenders hold everything in place until it heals adequately. So starting at the inside at the bone, going to the outside at the skin, resetting and recontouring, and then suspending. So that preoperatively, you're talking about releasing the facial ligaments. Postoperatively, you're anchoring the ligaments because it's the work on the roots that really create the fruits. So the order of the approach, I like to keep it simple. I start centrally, then go to the orbit, then lateral, and if I need to, extra-auricular. Bone, ligaments, smas, skin. So that's the order: central, orbital, lateral, and extra-auricular. That is 20 ligaments on the face that are all done from the inside that are released. It's a targeted approach. So sometimes we restore, sometimes we create. You take the same 4 belt muscles in every surgery you do, and you decide what to do and how to change them so that you can change that configuration to a more targeted central approach. So going down in the mouth, starting out along the jawline, under the middle nerve, and you have to make sure the bone, you're touching the bone the whole time. You have to rock and roll because you'll go into a different plane, and that's where the facial artery and vein are. You can work on the DO at the same time, go up into the mouth, up into the orbit, lateral approach, behind the lid, and remember, as long as you stay in that stairway to heaven, you're in a safe plan. You could deglove the face, you can use your smart hand, and remember, coal line is what I call, I've never seen it described, from the corner of the mouth to the top of the ear, where the primitive platysma ends and the zygomatic muscles start. So when you get in the neck, find the hyoid. Let me know if you know what that buckle means, and then put a buckle, sutures above the hyoid, below the hyoid. You could take somebody like this, give them a more reasonable result, centralize their ligaments, and look at their lower lid. You want it to be shorter. You want them to have cheek volume. So look at her lower lid. Look at her outer cheek on the 3/4. That's the improvement in the jawline. So here she is, age 26, and it's age 66 postoperatively. And here's a lady intraoperatively, so relaxed on top, tightened on the bottom. You can see the elevation of the right cheek. So here's the last patient. We started with a lawyer, we end with a lawyer. So she was losing a lot, and the jury was very poorly reactive to her. And so she had this surgery, and she came back. Angie was her name, and I said, "Why do you keep wearing these turtlenecks?" She said, "That's all I own." I said, "It's time to get rid of them because it's 2023 and we have a lot of options." So I think the future is now. Thank you for your attention.